dramatic health production.
Forget genius. In many ways, the significant advances in modern medicine can be viewed as little more than the product of a happy combination of dumb luck and coincidence. As you are about to hear, some of healthcare's most significant milestones were the result of fortuitous accidents followed by scientific rigor. But serendipity and science alone don't improve health and healthcare. It took curious, creative, and persistent individuals to bring these accidental discoveries from the lab bench to the patient bedside. These are their stories. This is Game Changers in Medicine. Hello and welcome. I'm your host, Dr. Ruben Pillay. I'm a professor of medicine and a professor of business at the University of Alabama at Birmingham Medical Center. I'm also a medical futurist. And by that, I mean that I look at how software, hardware, communication, and biomedical technology converge to improve patient care. And while it may seem odd for one focused on the frontier of medicine to host a podcast exploring medical innovations from the past, I can tell you that there's much to be learned from the scientists and clinicians who have preceded us. Our story today is about the discovery of vitamin K. Now, this discovery took place nearly a century ago, so you may wonder why we're choosing to debut Game Changers in Medicine with it. That's a lot of pressure to put on one vitamin. We chose it because the story of vitamin K encapsulates so much of what our podcast series is about. Monumental discoveries that happened in unexpected ways. Let's begin. There are close to 4 million babies born in the United States each year, and more than 130 million worldwide. By way of greeting, many of those babies are injected with a needle filled with vitamin K.
Newborns are vitamin K deficient. They don't have vitamin K, and breast milk is quite deficient in vitamin K.
That's Dr. Bruce Fury, a professor of medicine at Harvard Medical School and a world leader on vitamin K, hemostasis, and thrombosis research. He has countless awards and a few groundbreaking medical discoveries of his own.
The risk of continuing vitamin K deficiency over the first week or so is significant enough that it can lead to bleeding disorders due to the absence of vitamin K and the inability to make the vitamin K-dependent blood coagulation protein. It's the normal physiology. Vitamin K deficiency is not actually measured. Rather, all babies are assumed to be vitamin K deficient. This leads to a bleeding disorder. In its modest form, it could be ecchymoses, black and blue marks on the skin. In its most severe form, and this is what was a problem, is cerebral hemorrhage, brain hemorrhage. There are minimal, if any, complications with giving 0.5 milligram of vitamin K to a newborn.
For more about this, let's hear from Catherine Rue. Catherine is a nurse midwife who's delivered thousands of newborns. She's also the director of patient education at the Association of Women's Health, Obstetric, and Neonatal Nurses.
All newborns have lower stores of vitamin K at birth than what adults would have. And it's not because the mothers are deficient. It's really because vitamin K does not cross the placenta very well at all. Now, for the vitamin K injection, a really excellent recommendation is to administer the vitamin K while the baby is still with the mom. You give the baby the vitamin K injection while the baby is on the mom's chest, maybe even while the baby is nursing. That is a strategy to help minimize the pain of the injection for the baby, cuddled up with mom and nice and warm. Obviously, the nurses are very skilled and know how to do it very quickly and minimize any of the procedure for the baby.
While it's hard to quantify exactly the impact of vitamin K on infant mortality, there was a definitive study done in Sweden in 1944 that estimates that for every 100,000 full-term infants born, vitamin K would save the lives of 160 babies each year. Since 1961, the American Academy of Pediatrics has recommended that vitamin K be given to all newborns. That one vitamin K injection is really one of the simple and yet very effective therapies that have a history of long standing. Let's contrast this with the early days of vitamin K use. Listen to the words written by Dr. William C. Moloney, a pioneering hematologist who set up practice in Boston in the early 1930s. Dr. Moloney was among the first to test patients for vitamin K deficiency. In his memoir, Pioneering Hematology, he recounts the day George Allen, a close physician colleague, called him for an emergency consult of a newborn. We are fortunate to have with us Sean Moloney, Dr. Moloney's grandson. He's also the co-founder of Dramatic Health and the producer of this podcast series. I'm going to ask Sean to read that particular passage from his grandfather's memoir. Sean?
My colleague, George Allen, had just delivered a baby who was convulsing and bleeding from the nose, mouth, and into the skin. I rushed to George's practice in Norwood and agreed with his diagnosis of hemorrhagic disease of the newborn. I told George about vitamin K, and he was anxious to give it a try. At that time, vitamin K was not available commercially, but I knew two investigators at the Thorndike Memorial Laboratory at Boston City Hospital who were working on manufacturing it. They had just prepared a batch of vitamin K from leafy vegetables and offered to give me some to use on this infant. I dashed down to Boston City Hospital, procured the material in a homemade vial, and returned to Norwood Hospital. The infant was oozing blood, barely alive. I put the homemade vitamin K into a syringe and injected it into the infant's buttocks. The baby stopped bleeding and eventually recovered completely.
Thank you, Sean. That baby was likely suffering from the hemorrhagic disease that Dr. Fury was telling us about. Hemorrhagic disease of the newborn is now more commonly called vitamin K deficiency bleeding. Prior to the discovery of vitamin K deficiency bleeding could be fatal. It was fortunate that Dr. Moloney happened to read an article about vitamin K and was willing to take a chance on it as a therapeutic solution. What else could he do? At the time, there were no other alternatives for that baby. Could this happen today? Here's Dr. Moloney, now in his own words, thanks to the oral history he recorded for the American Society of Hematology and the Oral History Archives at Columbia University.
There was a disease in newborns called hemorrhagic disease in newborns, which found to be due to lack of prothrombin. And then it was discovered the antidote for this disease was to give vitamin K. This evolved over several years in the early 30s. So vitamin K was synthesized and isolated. Then you could treat vitamin K deficiency, which was a congenital deficiency from the lack of vitamin K from the mother to the fetus. And these children would bleed into the head, either die or be left crippled.
That's my grandpa. By today's standards, it's safe to say his practice was, unconventional. But then again, so was he.
It's stunning to me to hear your grandfather talk about the bleeding disease in newborn.
Yes.
Imagine the thrill for obstetricians at the time to finally begin to have an understanding of what had been causing it.
Sure.
I'd love to hear more about this grandpa of yours.
Well, I welcome this opportunity to tell you about him. Grandpa was well-known, well-loved, practicing in Boston from the 1930s to the end of the century. He started out in general practice and wound up specializing in hematology and leukemia. Throughout his life, but especially as a youngster, he was an avid sportsman. In fact, one intense hockey game brought him to the emergency room.
Right.
I believe it was Boston City Hospital, and he was diagnosed with a broken arm. The experience there got him thinking that he might make a better doctor than a hockey player. I'm sure his patients and probably his hockey coaches agreed with him.
Exactly.
My interest developed rather rapidly because I had a bad injury in which landed me in the Boston City Hospital for some weeks, and subsequently over a long period of time I was going back and forth. So I worked around the hospital summers as an orderly, as a matter of fact, and then went to pre-med at Tufts. In those days, you could get into medical school with 2 years of pre-med. You didn't have to have a degree, but you had to cram into those 2 years all of the scientific subjects that include physics, chemistry, and all the other biologic sciences. We had a very large class, and it was competitive in the sense that 1 out of 4 of us would get in the medical schools. So we all worked our tails off, and from being a somewhat unsophisticated person, I had to develop rather rapidly a competitive spirit about survival, and I did get into medical school, and I did fairly well. Considering the fact I used to work nights at the Motor Mart garage in the lobby on the cigar counter and try to go to medical school at the same time, which is kind of a chore, as you might imagine.
While Dr. Moloney is toiling away in medical school, there's a biochemist in Denmark named Henrik Dam who started a cholesterol study on baby chicks. He feeds the chicks a cholesterol-free diet in the hopes that it will shed some light on how cholesterol is synthesized. Pretty quickly, all the baby chicks started to hemorrhage. He tries everything to stop the bleeding, adding cholesterol back into their diet and then feeding them every known vitamin. Finally, he hits upon a solution, which turns out to be an extract from leafy vegetables. Dam realizes he'd discovered a new type of vitamin which he promptly calls vitamin K, taking the initial K from the Scandinavian spelling of coagulation. Coagulation is just another word for blood clotting, or blood changing from a liquid state to a semi-solid state. The big aha moment here is the revelation that the body needs vitamin K to create prothrombin and other blood clotting proteins. Prothrombin, a key to blood clotting. If you lack it, it can lead to uncontrolled bleeding. This is true whether you're a baby chick or a baby human. This was quite an unexpected discovery from a biochemist who was simply pursuing an interest in how cholesterol metabolizes. A few years later, another biochemist named Edward Doisy was able to determine the chemical structure of vitamin K, which allowed it to be produced commercially. This was a game changer in its own right, and Dam and Doisy shared the Nobel Prize for it in 1943. Let's pause here for a quick announcement. When we come back, we'll look at the critical role vitamin K played in making sure that it was safe for a patient to undergo surgery.
Thanks for listening to Game Changers in Medicine. Be sure to visit GameChangersInMedicine.com to join the conversation, access show notes, and discover even more content as it relates to this segment and others. Head over to iTunes to subscribe, rate, and please leave a review. It's very much appreciated. And follow us on Facebook and Instagram at Game Changers in Medicine. Thank you.
As you can imagine, any type of surgery on a patient who happened to be vitamin K deficient posed a high risk, but there was no way to know about a patient's vitamin K status in advance of surgery. A physician pharmacist named Armand Quick developed a simple test doctors could use to measure a patient's prothrombin level. Prothrombin is an indirect measure of a patient's vitamin K status. So the level of prothrombin measured would determine whether or not the patient's blood had the required clotting factor to make a surgery safe. The test was appropriately named the Quick test. Not only was it quick, it was easy to administer. If a patient were found to be vitamin K deficient, a preoperative dose of vitamin K would bring the levels up and mitigate any excessive bleeding during surgery. Here's Dr. Fury again to explain this further.
Prothrombin is a protein that circulates in our blood. We know the pro part of prothrombin is the part that makes it a vitamin K dependent protein, and the other side of prothrombin is thrombin, and that's the enzyme that is generated from prothrombin that goes ahead and activates the blood coagulation. It is necessary. If you're missing prothrombin, you're going to have a bleeding problem.
Dr. Moloney recognized that the quick test could be a real game changer for any patient about to undergo surgery. He gathered the few necessary materials, put them in a wooden cigar box, secured the box with a rubber band, got in his car and set out to administer the test at hospitals throughout Boston and beyond. He was one of the first, if not the first, to administer these tests to preoperative patients. This is a good place for me to introduce Dr. H. Franklin Bunn. Dr. Bunn worked closely with Bill Moloney, and they came to be good friends. We're fortunate to have Dr. Bunn with us to share some of his recollections.
He made do with what he had. In those days, there were patients who were thought to have serious blood problems that couldn't make it in to the Boston City Hospital. And so Dr. Moloney was sometimes spent a fair amount of his time on the road going to see patients as far away as central New Hampshire or western Massachusetts. And so he had to take a kit with him to enable him to make what would be relatively simple tests compared to what could be done in a hospital. They sufficed and provided additional information above and beyond what he could gain from talking to and examining the patient.
I'd be remiss if I didn't tell you about Dr. Bunn, who is affectionately known by his colleagues as Mr. Red Cell. He is a true hematology heavyweight. He's a physician, hematologist, and biochemist at Harvard Medical School. He has many discoveries to his name, including the co-discovery of hemoglobin A1C. Each day, millions of people around the globe receive the A1C test to diagnose diabetes and prediabetes. Dr. Bunn took over from Dr. Moloney as Chief of Hematology at Boston's Brigham and Women's Hospital. We'll hear more from Dr. Bunn later. For now, let's continue with Dr. Moloney describing how he did those tests.
In this test, you took some plasma and you put a measured amount of plasma in a little tube. You added what is called thromboplastin. This is a factor from tissue taken from the brain because that's a very potent source of it. And you put an amount of that in, and then with a stopwatch, you measured how fast this little plaque formed. You could see it form as a white film. That's called a prothrombin time. I began to go around to numerous hospitals, maybe 15 or 20 hospitals, because no one else in Boston would go out consulting. No one would go out and see the nitty-gritty things, like a bleeding problem. Or anybody like myself would carry their own stuff with them and do it, because these labs didn't have this capacity at the time. So that's how I got involved, through coagulation and blood banking. Now, at many other hospitals, you started at the bottom of the ladder and you didn't get your head up above the rest, or you get it knocked off very promptly. And they wasn't having some young upstart like me come in there and start doing things like these tests. The chief of my service, who was a nice, kindly gentleman, was very resentful of the fact that he wasn't getting these consultations, and I was, but he couldn't do the test.
As the demands for Dr. Moloney's testing services increased, he struggled to procure thromboplastin, which was the key reagent in that quick test. I'm happy to be able to call upon Dr. Fury again for an explanation of thromboplastin.
Thromboplastin is the old name for a well-known protein involved in blood coagulation called tissue factor. Tissue factor is a well-studied protein on the surface of cells. It is a membrane protein, meaning it's attached to the cell membrane. It is the initiator of blood coagulation. Now, thromboplastin in the old days was a rather crude mixture. It could have been called the ground-up rabbit brain test because brain has a lot of thromboplastin in it.
I have to say that the quick test is probably a way better name than the ground-up rabbit brain test.
Now, recombinant human tissue factor is fairly standard.
But in the early days of the quick test, commercial thromboplastin was tough to come by and expensive to boot. However, Dr. Moloney knew that thromboplastin from animal brains could be used in place of commercial thromboplastin. Fortunately, thanks to the close relationships he maintained with his patients, Dr. Moloney had a source.
I made my living mainly by telephone calls from the operators. There was an emergency system in those days where the operator would get a call and then she'd have a list of doctors. And there were a lot of older doctors out there. I was the first new doctor for years out in that part of Jamaica Plain. And the point was that there'd be all kinds of emergencies during the night and it'd get you up, at any hour. In the midst of the Depression, I got called down to a family that we befriended and over the years did a lot for. The family had about 10 children in Roxbury. The father had a job in a meat packing firm out in Brighton, and this is important because of what happened later. But they were a good couple, but they just didn't have any money. And I remember going in and seeing this woman who had twins about her 9th pregnancy, and both twins, the house was cold, they had practically nothing in the house, and they both had whooping cough. And I can recall this one kid was having convulsions with cyanotic flu. Well, I didn't know what to do, but I had read a letter in the Journal of American Medical Society which said that sometimes if you get a convulsive state, you can't control it. If you gave ether to the individual, it would quiet it down, and it could be given in oil as a rectal installation. So I got some olive oil from them, and I had some ether in the bag. I used to always carry things like that. I poured the ether in and mixed it up and took a rectal tube, which I carried also in the syringe, and injected. And the kid fell asleep. And the convulsion stopped. The other kid died. We got this little one into the hospital, and she recovered.
I can't help but think back to Dr. Moloney saving the baby in Norwood with the homemade vitamin K injection.
Over the years, we became very friendly. Later on, this man who was out at the abattoirs.
Abattoir isn't a word we hear much anymore, but it's just the sort of $10 word Dr. Moloney was always using. It's a fancy way of saying slaughterhouse.
Supplied me with a lot of the tissues I needed to make different things for the clotting studies. And I'd send some of the fellows from the state hospital out there to get brains from sheep or cows. He was very helpful in things like that. And he used to come up and help around the house. It reflects the intimacy you had with people. You go in and have a cup of tea with them, sit down and talk with them. Of course, they never had any money. Well, what could you do? If I suppose we're out in the farm someplace, they would bought me some bag of potatoes or something, but these people didn't have that.
Sean, are you familiar with this story?
So that night watchman at the slaughterhouse was Tom Brown. And I have to say that story became the stuff of legend in our family.
Now let's remember, Tom Brown is the father of those infant twins in Roxbury, the ones with the whooping cough and convulsions.
So I remember Grandpa telling me how he'd collect animal brains from Tom, and then work late into the night, over the stove and stirring the brains into a proper, I guess you call it a reagent. I have to think that this would have annoyed my grandmother, probably to no end. I mean, here's this husband of hers who's never shown any interest in cooking, and now he's taken over the kitchen. I would imagine she took it in good stride. But I do remember him telling me that one day she opened the refrigerator and a cow's stomach exploded in her face. Grandpa would assure me that he tried mightily to justify this. I'm not sure how, but explaining that he had been storing these cow parts in the refrigerator for important research he was doing. I can only imagine how that conversation went. But I do know that on that day, my grandfather's makeshift kitchen lab closed for good.
Your grandmother sounds like a saint.
She most definitely was. Fortunately, right about the time when the cow's stomach explodes in her face, commercial thermoplastin had become more readily available, and the demand for his services had increased to the point that he was able to move his practice proudly from Jamaica Plain, the living room in Jamaica Plain, to Bay State Road in Boston's Back Bay neighborhood. Despite this, what is a fancy address in Boston, he continued to drive this old blue Dodge throughout greater Boston and drive it wherever his patients needed him. He continued to care for patients throughout his career all over Boston. He had some extraordinary experiences that took him away from general practice. For one, he was appointed director of research for the Atomic Bomb Casualty Commission, and I believe that was in the early 1950s. He and my grandmother and 4 kids, including my dad, of course, they picked up and moved to Hiroshima for a few years so he could study the effects of the fallout of radiation on the survivors of the World War II atomic bombings. But that's a story and a podcast for another time.
Right. I'm really in awe at your grandpa's willingness to just jump in and do what's necessary to help his patients. And I must say, I'm also struck by the close and compassionate relationships that he seems to have developed with them. Let's hear more about that from Dr. Bunn.
Well, Bill Moloney viewed every patient as both a friend and one who needed help and who he regarded with enormous warmth. At the same time, he viewed the patient as a challenge. Oftentimes it would be a diagnostic challenge and even more often a therapeutic challenge, because in the early days of cancer and particularly blood cell cancers, the therapeutic options were kind of limited. And he was a leader in particularly treatment for acute leukemia and lymphomas. So there's this combination of his intellect and curiosity and drive to perfect treatment and diagnostic measures as well as treatment, along with never-ending affection for and respect for patients that didn't know any divisions of class, or money was never an object. And there were many patients who got superb care from Moloney without paying a bill. I first got to know him at the Boston City Hospital. I was in training at the Harvard Medical Unit, and we had very good research in our group, but very few patients. And we had a very limited clinic, whereas Dr. Moloney had a very large clinic that covered not only inner city folks, but referrals from all over the inner and outer suburbs of Boston. So he had a big influx of both outpatients and inpatients. So we went to spend time rounding with Dr. Moloney and seeing his patients to get additional experience. And he was very generous about that because it cost him time. And of course, he didn't get any remuneration for the teaching that he did in the unit at the Boston City.
Let's continue listening as Dr. Bunn shares memories of Dr. Moloney's legendary bone marrow course.
Bill Moloney felt it was very important for his trainees to be expert not only at the bedside with patients, but also to be able to read and interpret the microscopic examination of their blood and bone marrow. And so he prepared a course to review this material, but equally important, he shared time with us to look at the specimens of patients that had just been admitted and who were newly diagnosed with usually a bone marrow malignancy. It was known affectionately as the bone marrow course for at least 30 years. And he was a master at it. He loved sitting at a 6-headed microscope with 5 people, usually trainees, like residents or fellows. He had a collection that was amazing. That went back 30 or 40 years of slides from patients who were very instructive with various kinds of disorders. So then he'd prepare quizzes where he'd ask us to take time and look at these tough slides, diagnostic problems, And then we would, do our best. And then he would, give us some chances to go wrong. And then he'd tell us, what was really going on.
Dr. David Rosenthal, professor of medicine at Harvard Medical School, trained as a fellow under Dr. Moloney at the Peter Bent Brigham Hospital, now Brigham and Women's Hospital. He has some interesting recollections of his own.
I'll always remember when we were at the Holy Ghost Hospital in Cambridge. That's where he had his lab and his mice that he studied, the Sprague-Dawley rats. We would go over there, help the rats, feed them, take care of them, study them, draw their bloods, cut their tails so we could get their blood to do studies.
We all worked together and we did some rather crazy things in the way of investigation. And we didn't have computers and we didn't have a lot of the facilities we have today, but we were curious and we investigated these things the best way we could.
You've got to understand the times. There's lots of things that we did in those days that didn't go through institutional review boards.
An institutional review board reviews medical studies to ensure the safety of volunteers in human research. It typically goes by the abbreviation IRB.
We did lots of things that you would never have heard of to be able to be doing them at this time. When we came up with a new therapy, we didn't have to go to an IRB to get it approved. I see a number of studies going through now, and we have to look very carefully at efficacy, but most importantly, obviously, safety. And I'll tell you, the informed consent process is a tedious one. If you look at some of the informed consents that people have to sign, they're close to 30 to 40 pages long. So now they're doing summaries, and so that's going to help a little bit for subjects to be able to approve them.
Today, a new drug coming onto the market will have been through years of formalized testing for safety and efficacy. But that type of formalized testing didn't come into practice in earnest until about the 1960s. While there's no question that Dr. Moloney was dedicated to his patients, I think it's safe to say that much of the research that he did on their behalf wouldn't be possible today. This curiosity and interest in experimenting was a through line throughout Dr. Moloney's career. I can visualize him driving all around Boston with that improvised cigar box lab by his side.
My grandpa went the extra mile. Literally.
As we near the end of our episode, you've probably figured out that it is less the story of the discovery of a vitamin as it is a story of researchers, doctors, and clinicians who gave themselves the freedom to follow their curiosity and explore areas that no one else was investigating, or for that matter, even knew needed to be investigated.
I'm a great believer in serendipity. You can publish papers and do all kinds of scientific research, and I've published over 300 papers. But the number of really significant contributions is probably can be counted on one hand, and they were all serendipitous. You probably heard the expression, the prepared mind. One of the exciting things of doing medical scientific research is that you don't know where it's going to go. You follow your nose.
That was Dr. Bruce Fury again, and his thoughts are closely echoed by Dr. Bunn.
I think serendipity is huge in medical research in so many different ways. You can be lucky in identifying and encouraging and training an amazingly talented young person who could end up doing really wonderful things in, say, lab research or clinical research. Or you could have great luck in learning about a technique just because your lab happens to be next door to a lab doing unrelated work, and yet they have a technology that just fits perfectly with what you want to do as a research project. And then you have serendipity in terms of international relations, that when you go to meetings, sometimes you are lucky and pick up things that you never would have learned if you had stayed in the United States. So there's all sorts of networking, and the drug industry also plays a role in this. So yeah, there's a lot of good luck that's very handy in making progress in medical research.
It feels fitting to close this episode on those ringing endorsements for what can happen when serendipity meets science, and as Dr. Fury says, the prepared mind. Let's conclude with a salute to the spirit of discovery and those who came before us. The marquee names like Dam and Doisy, to be sure, but also the lesser known, inventive and enterprising doctors and scientists who by accident or fate changed the way patients are treated today. My hope is that their stories will inspire medical and non-medical professionals alike to take the time to explore the side paths, to follow where their curiosity leads, to do the modern-day equivalent of packing up lab equipment in a wooden cigar box and driving to patients' bedsides. With that, I want to thank all our listeners for spending time with us today. Thank you also to our special and esteemed guests, Sean Moloney, Dr. H. Franklin Bunn, Dr. Bruce Fury, Dr. David Rosenthal, and nurse midwife Catherine Rue. And yes, from the great beyond, Dr. William C. Moloney. I hope you'll join us for our next episode, where we explore the discovery of the smallpox vaccine. It has a colorful creation story and is considered to be the first medical vaccine developed against a contagious disease. Despite the vaccine being discovered more than 200 years ago, it was only in 1980 that the World Health Organization deemed the entire planet free of smallpox. May we soon be able to make a similar boast about the coronavirus, just in a shorter time. Thank you for listening to Game Changers in Medicine. Please leave feedback, comments, and ideas for medical discoveries you'd like to learn more about at gamechangersinmedicine.com. Game Changers in Medicine is a dramatic health production. Sean Moloney is the executive producer. Rolando Nieves is our showrunner and editor. Sharon Johnson is our researcher and writer. Lauren Wiegand and Tom Slivakowski are producers. Ryan Liatzis is our audio engineer.
A dramatic health production.